أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين. Dear friends and students, now actually we are dealing with the clinical radiology, and this is I want to discuss the case number 3, reporting clinical radiology. So this was the case number 3, and I am Professor Syed Ali Haider, representing as a visiting professor of medicine, Jinnah Sindh Medical University. So reporting the Xray case number 3. I am reading it and pick up the hard data from it, or soft data parallel to it. Now this is the data. A 30-year-old clerk who was under treatment for the urethral problem since 3 years and was on NSAIDs, non-steroid anti-inflammatory drugs, often and off and on for the severe low back pain for the last 10 years. Presented with effort intolerance now for the last 2 years at medical OPD. Presenting in the medical OPD, what is the complaint? It is effort intolerance. So examination, I examined this patient and found the temperature is 99 degrees Fahrenheit, which is a normal one. Pulse was 110 per minute. It is tachycardia, sinus tachycardia. It is regular but collapsing in character. Waterhammer pulse. So BP was 140 by 55. The pulse pressure is much higher. It is about, you can say 45 plus 40. It is 95. Pulse pressure is high. Always remember, when there is a pulse pressure is high, there will be the chances of collapsing pulse. A diastolic murmur at area 1, A1 area, aortic area 1, will be found and tenderness at the low back and the sacroiliac joints. I examined it and put the pressure on the back and the sacroiliac joint pointing. Restricted extension was noted there of the lumbosacral joints. It was demonstrated by myself, and Schuber's test, and another test was what is called a Wall's test. And you put the patient in front of the wall and see the back, examining the back, whether all spines are touching on the wall or not. It was not touching. So the patient is in the stooping position or flexion position. The Schuber was positive, and right upper chest showed the restricted chest movements at the upper part of the chest. It was left upper chest, sorry. And a bronchial breath sound at the upper chest and the bronchophony. Breath sound means that the inspiration and expiration are equal, and there is a gap between the first sound, breath sound, inspiratory sound, and the expiratory sound. Clear gap. And in bronchophony means this vocal resonance was increased at this area. BR. It's called bronchophony. Now, investigation of hemoglobin is 11 gram, total leukocyte count 7,600, normal. Platelet is slightly higher, 4,70,000. Normal is 150 to 350,000 or 300,000 in Pakistan. So it is more than 470,000. It means acute phase reactant is positive, although TLC is normal. The CRP was 68 is higher. Rather, lab shows that 7 is normal. It is much higher. The random blood sugar is 144. Urine RE showed WBC 8 per HF, and Xray chest PFU, which is the target to us, was taken and shown to you. As per clinical data provided above, report this X-ray. And this is what the X-ray was done. Now this X-ray showed what? First of all, the requirement has been done or not. So it is the dominant frontal view, PA view. okay, it is fine. The patient is still, as for straight, it was straight. Why? It was straight because the spine, look, the spine here, it is in line. And he was straight. Another thing which you can see, that he is standing. It means the first rib, second rib, third rib, fourth rib, fifth rib. Although there is a compensatory impassama is there, or there is difficult to recognize the seventh rib. So he is in standing position. And is still inspired, and the whole breath properly, because the broncho marking is visible here, here. It is not the expiratory film, it is the inspiratory film. Another point which we noted here are that afterwards, what are the other parameters? The parameters are the soft tissue shadows here on the lateral side, below the diaphragm, and in this area, this part. In the neck area, these are the soft tissue shadows. Nothing is abnormal in the soft tissue shadows. Then position of the trachea, you see the one line will be drawn here, another line will be drawn here, and then see the position of the trachea. Trachea is coming from the cricoid corticate down to its standard angle. This is the position of the trachea. Now here it is bending here. It is moving towards the left side, 10 degree to 20 degree on the left side. This is the position, about 20 degree angle. So moving on the same side. Trachea is displaced towards the same side. What are the conditions in which the trachea is displaced to the same side? Collapse of the lung, and second one is the fibrosis of the lung. Because of the sacralization and contractures, the trachea should be displaced to the same side. What are the conditions in which the trachea is displaced to the other side? By tumor, by the massive pleural effusion, and by the pneumothorax. It is on the same side, at that opposite side, pushing the trachea to the opposite side. And in certain conditions, the trachea is entrapped between the fibrotic strands, and either the pathology are present on both sides actually, and this is called splinting of the trachea. It means that there are pathology present in both apices or the upper zones, but the trachea is not displaced. It is called splinting of the trachea. So trachea is described here, then the lung field will be described, as I previously said, the first rib and second rib, draw a line. At the fourth rib, draw a line, linear, straight line, horizontal line. So the lung fields are divided into upper and right upper, right middle, right lower, right upper, and left upper, left middle, and left lower. Now two things should be compared. The lung field should be compared from here to here, 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 like this. Two things are normal, aerograms and the bronchovascular marking. Their proportion are important. Here the bronchovascular marking are seen somewhere. But here there is no bronchovascular markings, very hardly seen. Small, very, one or two or three. It is not absolute aerogram, but there are some bronchovascular markings. This occurs because of the hypertranslucency. It is known as compensatory emphysema. The pathology is there. Means about 25 to 30% lung is gone. So this person has got the bilateral features of the compensatory emphysema. Compensatory emphysema, emphysema, or whatever you call this condition. But another important point, in the left upper zone, there is alien. And this is the dominant type of the what it is. It is a pulmonary nodule, which means the opacity is single. Secondly, it is homogeneous opacity, dominant, although the aerograms are there, but more haziness is there. If it is homogeneous opacity, that is very homogeneous dominantly, there is no curve is seen here, basically, this part. So homogeneous opacity is homogeneous opacity with a curve, without a curve. It is without a curve. So is it the air bronchogram pattern you see here, something like this. I describe this case as there are, because there are a lot of strands out there. Because appearance looked to me as a homogeneous, but on a deep study, I found this one, this strands, these strands, these strands, these strands. So this is a reticulated type of opacity. It is non-homogeneous because of the reticulation here, aerograms here, aerograms, 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 aerograms. In the second look, I studied deeply that it is a reticulated opacity, thick fibrous bands are there in this area, which is pulling the trachea towards the same side. So this part of the lung has got loss of function, and there will be compensatory emphysema. And the right dome of the diaphragm is here, it is flat because of the compensatory emphysema. The costophrenic angle is not visible here. The cardio is all right. On the left side, you see this is what is known as it is the pointing type of a dome, left side of the dome of the diaphragm. It is called tenting of the dome of the diaphragm. And tenting of the dome of the diaphragm is pleural fibrosis, basal. It is caused by many conditions, autoimmune diseases, the tuberculosis, the fungal infections. There are many causes of the tenting of the dome of the diaphragm. The overall picture is representing the fibrotic nature of the disease, restrictive lung disease. It is a restrictive lung disease, so the intercostal spaces you see here is very difficult. It is less than 2.5 centimeters here specifically. So there are narrow spaces also seen in this case. Then we study the lower part of the middle mediastinum. A line is drawn here and here. This is the upper part, this is the lower part. The size is within normal limits, rather it is what called small heart. In emphysema, the heart is straight, or heart will be small. Somebody will call it the microcardia. There is no terminology like microcardia. वो कहते हैं ना कार्डियोमेगाली, तो कार्डियो माइक्रोलॉजी, no such thing. Megali and micrology, no micrology. Terminology is wrong. Straight heart, small heart, yes, it is. These are the correct terminology. The upper part of the middle mediastinum, I will divide imaginary line here into four. The first part representing here as the ascending aorta, the second and the third one here, the arch of aorta, although it is not visible, the aortic knuckle is here in this position, and then this is the pulmonary conus, which is obstructed by this. So the border of the heart is obstructed. It means Silhouette sign is positive. Either the upper part of the middle mediastinum is obscured, or the lower part of the middle mediastinum is obscured. Means Silhouette sign. Silhouette sign is present. It means the pathology is in the pulmonary parenchyma. So the shape of the heart is right border of the heart, it is the left border of the heart. It is very straight borders. These are straight borders. Lastly, but not the least, are here you see the very small, the left highlight is not visible very correctly here in this position, because of the isodensity of the fibrotic strands. On this side it is visible, although it is detected on this side, the upper part of the middle mediastinum, although the clear-cut right highlight is not visible. Only lower part here, the upper part and the stem. So these are the reporting, and the inference is that this person has been suffering from the fibrotic nature of the disease, affecting predominantly the left upper zone involving the epices. There are thick fibrous bands present on this area, and they are pulling to the same side. The trachea is shifted to the same side. And there is compensated emphysema, and there are tenting of the dome of the diaphragm, which means the disease is of fibrotic in nature. Now, if you go further, what other investigation you want to do to confirm the case, a lot of investigation can be done. The data review first to see this pathology. If the patient is can be afforded, it can be, you can do the HRCT. More than that you can do. The study can be done by taking the biopsy, bronchoscopy, sputum, always taken by these patients for the exclusion of the tuberculosis. Because this is the first thing in the world which causes so much fibrosis. The other disease which can cause in your mind will be, that should be, is autoimmune diseases. Because see the hard data, the patient is suffering from the musculoskeletal disorder. Predominantly the lumbosacral spine and the sacroiliac spine. Schubert test was positive. The wall resting test is positive. The acute phase reactions are increased. These are indicative of some autoimmune nature of the disease. This is a seronegative type of arthritis, which is called ankylosing spondylitis, most probably. So ankylosing spondylitis based upon the presentation, clinical examination, and the radiology. Lumbosacral spine X-ray should be taken in this patient. And you will see specifically the sacroiliac joint obscuration. And you will find the banded type of spine in the lumbosacral disc. You will see, I will show you, if I will be alive and able to show the spine, how to read the spine X-rays. Do you want to refer this patient to? Yes, you can refer to the rheumatologist or internist. You can refer to the specialist which are dealing with autoimmune diseases, and you can also refer to the pulmonologist to see the pulmonary disease efficacy. He will do the PFT, pulmonary function test, but actually the internal medicine person can handle it. I can handle this patient well. So this is my case, I will say. I will not going to refer. I will go for the investigation which are necessary and manage it pharmacologically, and probably the surgical measures can be done. Physiotherapy has got a higher role in this case. This is the presentation which I want to give about the reticulated opacities which are fibrotic in nature and pulling the trachea towards the same side. I hope you have enjoyed with my reporting of this X-ray, and I am relating this X-ray with the clinical data also. So remember, these type of X-rays do come to you. So report these X-ray properly. Inshallah we will meet again for the case number 4. I will do 6 or 7 or 8 cases, and then I will switch to the pulmonary function test. But first of all, try to remember how to report it properly. Write it down on the piece of the paper, my findings, with this X-ray, and you can repeat it afterwards very well. Assalamu alaikum. Subhana rabbika rabbil izzati amma yasifun. Wa salamun alal mursaleen. Walhamdulillahi rabbil alameen.